Thanks very much for being with us. I'm Dr. David Morwood, and this is Your Health radio and television program. I'm very pleased to have as my next guest Dr. Michael Corley, anesthesiologist. Dr. Corley, thanks very much for being here.
Thank you for having me.
Dr. Corley, there's a lot of misconception about what you guys do, and I think we want to correct some of those misconceptions. Now, tell us about what your average day is like. What's your average day, say, at the hospital or at the outpatient surgery center? What do you do during your day as an anesthesiologist?
Well, I think that's one of the real positives about the field of anesthesiology is the variability in your day. There really is no average day other than every day is different.
Okay.
It's completely dependent on the surgeon that we're working with that day. Potentially I could be taking care of a 6-month-old. The next case could be a 92-year-old. The first case could be a mass excision on someone's forearm. The next case could be a thoracotomy, and we're taking wedges from someone's lung. So there really isn't a standard day.
Okay, so it sounds like for a hospital-based anesthesiologist or someone who's mainly concerned with surgery, you're responsible for giving the anesthetic for a patient who will have an operation. So tell us a little bit about the training program and how you get to become an anesthesiologist.
Well, you first receive a bachelor's degree from a four-year university, apply to medical school, gain acceptance to a medical school, receive your medical degree. At that point, you need to be accepted to a residency program. All those residency programs are 4 years for general anesthesia. At that point, you have the option to complete a fellowship. There are specialized training in cardiac anesthesia, pediatric anesthesia, pain management. At this point, there are some new fellowships that are in development, such as regional anesthesia, so the field is still growing.
And Dr. Corley, you're working now here in Monterey.
Yes.
And you're primarily working at the hospital, community hospital in Monterey Peninsula.
Yes.
So let's go over that training again. So everybody goes to college who wants to be an anesthesiologist, and they need to get a college degree. Following that, it's 4 years of medical school. Following that, it's a minimum of, minimum 3 or 4 years of anesthesiology training. Now, the first year, do you do an internship or do you go right into anesthesia training that first year after medical school?
No. You need to perform an internship. That internship may be a surgical internship, a medicine internship. I actually participated in what's called a transitional internship, which is a combination of both medicine and surgery.
Okay. Now, tell me specifically something about your training. Where did you go to college and medical school and get your anesthesia training?
Well, I pretty much bounced around about half of the Pac-10 at this point. Undergraduate studies was at the University of Washington in Seattle. I then went to UCLA for medical school, and then the University of Arizona for my residency.
Well, Dr. Corley, I trained mainly at USC, and had I known you were from UCLA, I may have had second thoughts about inviting you. I'm just kidding. But USC and UCLA, we have a nice, friendly, competitive rivalry, don't we?
Yes.
Down there in Los Angeles.
Yes.
So but you're basically West Coast trained.
Yes.
You're from Washington and Arizona and Los Angeles, etc. And now you're in Monterey. Well, it's great to have you here. Because I believe that there's a relative shortage of anesthesiologists, I think, in the country now, aren't there? I think there are more jobs available than there are doctors to fill those jobs.
Yes, without a doubt. In the early 90s, there was legislation passed that actually restricted the numbers of residency positions that were available for anesthesia because the government believed that we were in need of primary care physicians. And I think they underestimated the ballooning of outpatient surgeries and total surgeries that are being done in the nation as the population has aged, the number of surgeries, and also the innovations of surgeons being able to develop new procedures has really grown. And without the compensatory growth of the field of anesthesia, now there are more surgeries being done than there are anesthesiologists. So there really aren't enough anesthesiologists in a lot of areas of the country. You may not be able to find an MD to perform anesthesia. You may have a nurse take care of you under the supervision of an MD.
I see. Well, Dr. Corley, we're happy to have you here in Monterey, and we appreciate all the hard work you do. Dr. Corley, one of the topics I want to cover is selecting the type of anesthesia. Yeah, you know, as an aside, most of our viewers and listeners know that I'm a plastic surgeon, and when I counsel patients in the office, or my clients or customers in the office, they're routinely happy to sign up to have a facelift or liposuction or a reconstructive procedure, but many of them are so concerned about the anesthetic that they're going to have. Whether they get a general anesthetic or spinal or regional or sedation, there's many anesthetic options for people to consider. So Dr. Corley, let's go over how you counsel a patient about selecting the proper anesthetic for a surgical procedure. What do you want your patients to know?
Well, I'd start off by saying anesthesia has really come a long way in the past 20, 30 years in terms of monitoring, in terms of new developments in pharmacology. It's really become one of the safest fields of medicine today. That being said, the first issue that I address when I see a patient is determining what is the safest route to take with that patient. For the most part, in a healthy patient, there is a minimal relative increased risk with different forms of anesthesia. For a young healthy person, I would really leave it up to their preference and what they would be more comfortable with in terms of procedures where they would have options of going to sleep or being awake. In patients that have more medical issues and the risks become greater with different forms of anesthesia, at that point I would counsel the patient to take one route or another.
So most of our viewers and listeners know what a general anesthetic is. One way to say it is they go to sleep or they take a nap during the operation, and their comfort level is controlled, and you carefully monitor their respirations and their heart rate, etc. But for the patient who does not want a general anesthetic, or you advise them to have another type of anesthesia, what are some of the options? Can we talk about a spinal or a regional anesthesia or sedation? Can you go over some of those options?
Sure. Going from the least invasive to the most invasive would be what's called a MAC anesthetic, or monitored anesthesia care. I think the layman term is kind of conscious sedation.
Or twilight, right?
Yes.
Some people say that like they get the twilight gas or the twilight medicine and they're kind of half asleep and half awake.
Correct. From there, peripheral nerve blocks and regional anesthesia is a little bit less invasive than some of the other forms because you don't get systemic exposure to the anesthetic. There's also what we call neuroaxial anesthesia, which is also has to do with your nervous system, but specifically your spine, whether it be an epidural or whether it be spinal anesthesia. And then finally, what we term as general anesthesia, which usually consists of volatile or inhaled gases that keep the patient asleep. We don't always have an option as far as whether or not we have a choice. If, say you had a laparoscopic procedure in your abdomen, you have to go to sleep, you have to have an endotracheal tube in order for you to be able to be ventilated. The surgeon would inflate your abdomen in order to be able to visualize the organs. That high pressure against your diaphragm would prevent you from breathing. Hence, you couldn't be awake for that. You couldn't have a spinal for that. You'd have to go to sleep.
Okay, so Dr. Corley, that's very important, and I appreciate you bringing this up. There are certain procedures where someone needs to have a general anesthetic. They need to take a nap or go to sleep during the procedure. A major abdominal operation, some major chest operations, is that true? That they have to really go to sleep for that?
Well, it isn't necessarily determined by how big the operation is or whether it's a major operation. One of the biggest vascular procedures that you can perform would be the repair of abdominal aortic aneurysm, and I've performed those with epidurals because it's an open procedure. So physiologically, the patient would be able to ventilate on their own because their abdomen is open to air and their diaphragm wouldn't be pushing against pressure. Now, they could have what would be considered a minor surgery like an appendectomy, but if the surgeon would like to perform it for cosmetic reasons, laparoscopically, they'd have to go to sleep. So it really depends. It's really surgery specific.
Okay. Now, one of my favorite types of anesthetic to use in my practice, and you guys are really terrific at this, whether it's a facial operation, whether I do like eyelids or a neck lift or even hand surgery, is that you guys will give them heavy sedation even for 60 to 90 seconds, and that allows me to get a local anesthetic in and make the area numb, say make the neck numb or make the hand numb, and then you allow the patient to kind of come to and become awake after the numbing medicine is in. Isn't that right?
Most definitely. I think without a doubt, less is more in terms of anesthesia. If I can avoid having to control your breathing, if I can avoid having to give you medication that potentially is going to depress your heart's ability to function, the less risk, the better. So a MAC anesthetic, if we're able to perform the surgery that route, I definitely would recommend that to across the board to just about any patient. So in the situation that you're referring to, if we can keep you comfortable but still keep you awake, that's what I push for with my patients.
Okay, and Dr. Corley, I want to emphasize to our listeners and viewers, and I know this is something that you personally are really good at, is that even under, say, the twilight anesthesia or other types of anesthesia, you are very carefully monitoring them, right? You have the cardiac monitors on and you can watch their airway, so they don't need to feel that if they're twilight, under twilight anesthesia, they don't need to feel like nobody's watching them, right?
No. I stay with my patients from the time that they're anesthetized to the time that I drop them off on the recovery room. They're being monitored not only on a minute-to-minute basis, but a second-to-second basis in terms of cardiac monitoring, their respiratory function, their oxygenation, the carbon dioxide they breathe off. So we monitor them very closely, keep a watchful eye, and vigilance is the key word in anesthesia. Right.
Well, Dr. Corley, I don't mind letting our audience know that I've been lucky enough to work with you a number of times, and you're really good at that, and you watch your patients, or watch my patients, very carefully. And
Thank you so much.
I appreciate that. Now, let's talk about some of the other things that anesthesiologists do. It seems like you guys, like the world of anesthesia is really growing larger and larger. Some anesthesiologists work in the intensive care unit. Some of you guys only take care of the pain patient and give blocks and prescribe pain medicine, etc. Now, do you have a favorite area of anesthesia? Do you prefer to go to the operating room, or do you like to work in the intensive care unit or take care of the pain patient, etc.? What's your favorite area?
Well, that's part of the general training in anesthesia is intensive care. Spend up to 6 months in the intensive care unit where I trained. We had a surgical trauma ICU, and so I had extensive experience in taking care of patients in the ICU and getting a medicine experience. In terms of pain management, most people that perform a fellowship, in order to be a pain management doc, you need to perform a fellowship. And if you're motivated to perform a fellowship, that's usually going to make up the majority of your practice. So doctors that are involved in that, usually, that's kind of their niche, or that's their area of interest, so that's where they spend most of their time. That doesn't mean that they don't also perform anesthesia in the main operating room, but usually they have a practice in and of itself that consists of pain management. For a general anesthesiologist, because you have the experience in the ICU, many ICUs across the country are run by anesthesiologists, so you don't need to perform that fellowship. If you want to participate in the ICU, you can go get a job in the ICU, and you're very well trained.
I appreciate that, Dr. Corley. Now, let's talk a little bit about, say, if a person is going to have a shoulder operation or an elbow operation, and I do a lot of hand surgery, and you see that patient in the holding area or preoperatively. Tell us what options you give that patient for anesthesia. Can we talk about a regional block or a local anesthesia or a wrist block, or, again, taking a nap during the procedure? How do you help that patient to decide?
Sure. Well, it really is surgery specific. You mentioned shoulder surgery. Shoulder surgery, rotator cuff repairs in orthopedics are notoriously painful postoperatively. For the procedure itself, most likely because of the surgical field, the location to the patient's head, the patient needs to go to sleep. And so they'll have a general anesthetic with an endotracheal tube. Some anesthesiologists perform them with what's called laryngeal mask airway. Post-operatively, what I can do to reduce their pain for 12 to 24 hours is perform what's called a peripheral nerve block. Usually those are performed before the surgery, but they're performed for post-operative pain relief and not for the surgery itself. Myself, the way that I perform peripheral nerve blocks is I use real-time guided, ultrasound-guided nerve blocks. So I use the ultrasound machine and a very small gauge needle and place local anesthetic in real time around the patient's nerve that innervates the area being operated on. And that allows them to have, a good day's worth of pain control and reduces the amount of narcotic they have to use, which is unfortunately has nasty side effects, as many people who have taken narcotic know.
Right. Well, Dr. Corley, we have about 60 seconds, and I want you to know I appreciate very much you coming on the program. I hope you come again. I do have one final question for you. In my practice, and I'm sure in many other surgeons' practice, sometimes the patient will want to speak to an anesthesiologist ahead of time, like they might want to have a conference or a consultation a few days or a week ahead of time. Is that available or possible here in Monterey for a patient who wants to sit or talk to their anesthesiologist?
Sure. You probably be able to talk to a anesthesiologist. In terms of our practice, we really don't find out who our patients are going to be, unfortunately, until the day before the surgery. So often we have a chance to, I interview my patients usually about half an hour before the surgery and do an entire history. If you wanted to arrange to speak to your anesthesiologist a week ahead, that could happen. Definitely at CHOMP.
And I believe that there's somebody on call for questions, and if the patient wants to talk to somebody, at least we can find somebody to go over their anesthetic options with.
Absolutely. Absolutely.
Dr. Michael Corley, anesthesiologist, you're here in Monterey. Thanks very much for being here. Appreciate it.
Thanks for having me, Dave.
I'm Dr. David Morwood. I am a board-certified plastic surgeon, and this is Your Health radio and television program. Thanks very much for being here. I hope you come by and watch the program and listen in again. Thanks so much. Thanks very much. Really, we're still live for just a second. We're almost done. So great that you come. Thanks a lot. I think, yeah, we're still visual. The mics will be off in a minute.